First, I want to let you know that Dr. K is a movement disorder specialist at the Minders Center for Movement Disorders in Oklahoma City. He received his fellowship and residency from the University of Texas Southwestern Medical Center, and he's an American board certified in both psychiatry and neurology. So let's get started. My question for you is, who are you? How did you get into this work, in particular, working with people with Parkinson's? And then what is your clinic like in Oklahoma?
Well, first off, I grew up all over the world. I mean, I grew up in the Middle East, Dubai, Abu Dhabi, worked in India, studied in India as well, and then moved to America probably, it's been almost 20 years now. I've been practicing almost 20 years as well. Well, actually 21 now. Sorry, time flies. The reason I got into this line of work was there's always been a need. I've seen that over the years. I mean, I've seen some of my close relatives have very severe neurological disorders, some of them with extremely severe debilitating diseases like polio. And I remember most of my family members are still in India, and we just eradicated polio just a couple of years ago. It's very hard, just like how you guys are seeing with COVID. It's very hard to hit 80 to 90% of a population, which is a billion plus, and eradicate a disease. So a lot of us still would get the bad neurological effects of polio, which would be similar to a movement disorder, very, very bad form of a movement disorder in some cases. And all of this sort of, just started working, slowly in my mind, way back as to why couldn't we find better solutions for these folks. Even as a kid, I remember my distant uncle who had one of these sort of disorders was called Scary Grandpa by the grandkids because he looked pretty scary with all his movements. Kind of like sometimes that we see with big, bad, flailing dyskinesia in Parkinson's. And so while he probably felt it was endearing because at least it's some sort of interaction with children that he gets, he could barely speak. But I kind of felt like, why did he have to live like that? Was there no medicine we could help with this? And strangely enough, now we have tons of medicine options for that same individual, which I had seen like 30, 40 years ago. And so these were the sort of things which got me rolling in terms of joining medicine as practice and as an occupation. So I started med school when I was 17 and finished up and started teaching at the local medical school. And before you know it, I'm here in America. And movement disorders became the easy way in. So the one major constraint, which most movement disorder docs, I know some of the other folks in this panel here as well will echo the same thing, is the fact that we don't have enough support, because it's not a one-man show. No matter how great you could be with manipulating medicines for this person, that's not it. As you guys just chimed in a little while ago, exercise, nutrition, the way you think conceptually of yourself, about your family, it's a very holistic approach, which we need to have for neurological disorders, especially a disorder like Parkinson's, which hits so many different circuits. And so the one major thing which we strived for in Oklahoma was to build a center of excellence. And many times, a center of excellence for movement disorders or Parkinson's entails a whole bunch of people coming together under one roof, which many times is structurally impossible even for larger university setups, because you have your physical therapist and your occupational therapist and your speech therapist is sitting one block away in the allied health sciences building. You have your psychiatrist in another wing of the medical school. They're just so disjointed. We don't have a cohesive team. And so that's what we've tried hard, and with a lot of donor support, we were able to build the Minders Center, which is an integrated form of practice where we have on-site physical therapists, speech therapists, neurosurgeon, we have the whole team. And when patients come in to see us, this is not just one-time eval. This like every single time they show up, they're seen by the whole battery of people. Not just my input that matters. I need to know what the speech therapist thinks of this person's speech or swallowing issues. We want to catch these things early and nip it in the bud, because a lot of times what a lot of you guys who've been through this for a few years realize is that once you let a few things slide, then it's hard to recover back from that unless you try real hard. So it's so much easier to nip it in the bud, kind of like an oil change, right? You don't wait for the car to break down and then do the oil change. You do it every year, preventive maintenance. That's the concept of our clinic.
Great. So Connie touched a little bit on this, but if you could let people know specifically, what is a movement disorder specialist? You know, how are they different from a general neurologist for the most part? And then also, why is it so important to, even if you live far from one, and even if it's a bit of a challenge, why is it so important to make sure that they are part of your team, even if you only see them once a year or every couple of years?
So a movement disorder specialist is a general neurologist who is subspecialized in one field of neurology, which is movement disorders. Anything to do with funky movements, tremors, Parkinson's, funky postures, balance disorders. This subspecialty is handled by neurologists who've had extra years of training, usually 1-2 years of extra training. And this is all they do typically, day in, day out. All they see is complicated movement disorder patients. I mean, they can see the earlier cases as well, but they have the extra know-how to deal with this particular disorder. So a general neurologist deals with all elements related to the nervous system, like your stroke, your migraines, your seizures. So he has enough information about all of them. So when you compare your primary care physician to a neurologist, yes, a neurologist is a specialist who could make a diagnosis of Parkinson's pretty easily. But then beyond him comes the movement disorder specialist, who knows more of the latest research, who knows some of the newer medications, or many times when complications arise, or the nuances of treatment in every Parkinson's patient. So those are the kind of things, because that's all they do day in, day out. So the more subspecialized you can get with your physician, the more you're going to get out of that visit, because they know much more about this disease than the general person.
Right.
Always is in the same way you want to think about for all disorders, right? Your primary care doctor can manage your blood pressure and your heart problems, but after a while he says, go to the specialist, the cardiologist. After a while, the cardiologist says, go to the surgeon or the interventionalist or the EP specialist who puts in your pacemaker. So everybody has a tier above, because medicine is so vast, you can't learn everything. You can, but you can't keep practicing everything. You won't keep being good at it or on the cutting edge.
Right.
And so the need for movement disorders comes to sort of have that overall game plan that in your disease course. Okay, this is what we're going to plan for your disease. This is what we're looking at in terms of milestones. This is where we're thinking of probably starting X therapy, or this is where you need this intervention. They make the overall plan. Many times your local neurologists, if they're in good relationship with the movement disorder docs, which usually is the case, they follow through on that plan. Okay, we started you on Carbidopa, and we're going to gradually build that up. Your local neurologist is going to tweak that and get it just right. We're going to start you on, this medicine for your dyskinesia. He's going to see in 1-2 weeks what's going to play out in terms of side effects, any tweaking or adjustments. Okay, and it's vice versa too. The local neurologist might say, hey, I can't deal with this person's foot drawing in so excessively. It's very hard. What do we do about this? All right, bring him in. We can do some injections. So these are the kind of things. So this back and forth relay between the two groups. It's like a tag team approach.
Great. Yeah. One thing also that I remember somebody telling me was that one of the things that your movement disorder specialist would know that other people, they might know about clinical trials, right? They might know about like the latest and greatest that's happening with Parkinson's. And for some people, I know some people who did not have a movement disorder specialist near them, or they couldn't get in with them. They actually started on a clinical trial, and they were getting much more time with the movement disorder specialist, because the clinical trial was requiring that. So that's just something to look at if, especially when you're new. A lot of the clinical trials require people to not have started medications yet, or not to be having DBS yet, or something like that. So definitely worth checking out. How do people get Parkinson's? How does it begin? And even more so, is there a clue that of the way Parkinson's is manifesting in somebody that can offer a clue to how quickly or that it might progress? Are there different types that you see?
So Parkinson's disease primarily is a damage of a circuit in your brain called the basal ganglia, and it deteriorates in a particular manner in which you show very specific symptoms, which is slowness, stiffness, and shaking, usually at rest, starting in one body part, gradually making its way to other body parts over the years. We're talking about a very long disease. If you develop this in your late 50s or 60s, we're talking 15, 20, 25. If you develop this in your 30s or 40s, it's pretty much a lifelong disease. It's like you got a chronic illness like diabetes. You just live with this all your life. These sort of disorders, we know the end result, which is that this circuit is getting damaged. We know microscopically what this damage looks like as well. We look at these nerves, there are very specific protein accumulations within these nerves as well. All of this is very classic. We can pick this up. But what we don't know is what instigates this damage, because Parkinson's doesn't develop in a day or two or in a month. It takes years. It gradually brews in your brain over years to slowly pick up and create the damage enough to manifest the symptoms. And so we're talking 5, 10 years out, or even 15 years out, you're probably starting to develop symptoms, which many times can be very subtle and many times non-physical. Why is it non-physical? Many times to get to the Parkinson circuit, there are so many other nerve bundles around it, under it. And so the theory is the disease can spread through all these different angles towards the Parkinson circuit. And so when eventually the Parkinson circuit gets damaged just right, you start to show your symptoms. So what could all those subtle symptoms be from other circuits being hit? Losing your sense of smell, constipation, starting to talk or acting out in your dreams, mood fluctuations, because these are all the adjacent circuits around it. So you kind of have to hit them to get to this. So in hindsight, a lot of y'all might start to think, you know what, you were telling me I was talking in my dreams, I was acting out, mumbling, saying stuff for like the last 5 years. Or you know what, I started losing my sense of smell. I couldn't pick up, unless it was a really strong cologne or perfume, I couldn't really pick up the fragrances anymore. So these are things in hindsight, which nowadays we are using to our benefit. Like we're using the lack of smell as a form of early identification many times, and we're trying to refine that. It's still not what we call, statistically speaking, highly sensitive or specific to use on a day-to-day basis. But that is one way of looking at. Somebody had mentioned if wish there was like a quick test where we could just quickly pick up. It is being refined, but it's not to the level where we can use it on a day-to-day basis. There are other approaches too. For example, a lot of us go get a sleep study for various reasons. I'm snoring, I'm waking up fatigued. As part of your sleep study, many times this talking in your sleep, this acting out of your dreams, it's what we call REM behavior disorder, gets picked up early. And so while there can be other disorders which can create REM behavior disorder, Parkinson's and similar disorders is a big chunk of that. And so when sleep doctors pick up on that, usually they'll give us a call and say, hey, do you want to just take this person on board and see if you can find the earliest symptoms of Parkinson's, yes or no. If not, you want to just keep following him or put him in a trial for early disease or send him for genetics, things like that. So we're getting better at catching the disease before your first physical symptoms start. 4, 5, 6 years out, we're starting to get much, much better at it.
So if, let's say there are, somebody's tremor dominant. So when they finally, figure out that they have Parkinson's, it's tremor is like their really big issue, their big motor symptom. Is there any evidence for, let's say, you have A, B, or C as your primary symptom, and then this is usually a more progressive track of Parkinson's? Or is there anything like that? Is there anything for people that are like, oh yeah, some of these types of Parkinson's actually progress faster?
So just to back up a bit for folks who didn't understand what that meant, tremor predominant. Remember the three things which I talked about: slowness, stiffness, and many times shaking, which is a resting tremor starting in one body part. So sometimes some of these symptoms are more prominent than the rest. And so if you have a patient who has predominantly a lot of shaking, their hands are tremoring both sides, their chin is tremoring, their leg tremors, it's very evident. Sometimes even when they're doing stuff, their hand is shaking. We call this pattern more of a tremor predominant Parkinson's disease, as opposed to the other kind, which is more of that slowness and stiffness, the akinetic rigid. So akinesia is a technical word for saying no movement or very little movement. Rigid means that stiffness is the technical term for the stiffness. So akinetic rigid forms, postural instability forms, your tremor predominant forms. So there are different kinds. So within this subset, we've seen traditionally that the tremor predominant kind tend to have a much more stretched out, longer profile. Their milestones are much more stretched out. So they seem, while they have very obvious looking tremors, they don't seem to decline in other fronts as bad as some of the other forms of Parkinson's. Why exactly this happens? We're still not fully elucidated the whole mechanism of why that happens, but this is something which we have seen, both anecdotally in my practice and shared by other colleagues within the movement disorder spectrum.
Okay. So carbidopa, levodopa is the gold standard of Parkinson's medication. So can you talk a little bit about what it's actually doing in the body, and then what's it doing for symptoms, like what sort of symptoms it helps with?
If you break down, many times when you see this drug and it's prescribed, it'll say carbidopa / levodopa, of which really levodopa is the main stuff that we really want. Levodopa is a precursor, meaning it is one step before the actual chemical that we're interested in. It becomes dopamine in your nerve cells. So meaning levodopa is taken up by your nerve cells convert it using enzymes to dopamine. And dopamine is a neurotransmitter, meaning nerves, the way they talk to each other is, electricity passes down a nerve. As it comes to a nerve ending, and there are other nerves sitting around it, this nerve, as the electricity hits the end, a neurotransmitter is released, a chemical is released, and that goes and connects to other nerves, kickstarting the electrical flow again. So this is how nerves crosstalk. And in this particular Parkinson circuit, dopamine is lacking. And preferentially, the nerves making dopamine or shooting out dopamine is getting preferentially damaged, whereas the guy receiving dopamine is relatively healthy. Which means if I can introduce dopamine from the outside or dopamine-like medications from the outside, I can kickstart these nerves back up again because they're relatively healthy. This guy's getting damaged, but I'm going to just give it more fuel for the fire. That's it. That is in essence what levodopa is all about. So think of it literally like gasoline for these nerves. So all you're doing is refilling the gas tank from the outside with external gasoline, external dopamine. That's levodopa. And all you're trying to do is keeping your nerves switched on throughout your awake hours. Kind of like you're topping off your gas tank before it gets to empty. Because when your nerves are switched off, they show all these symptoms which we just talked about: slowness, stiffness, tremors. You start to shuffle. You lose your facial expressions, your speech pattern changes. There's a multitude of physical combinations of slowness and stiffness in different body parts. All of this starts to disappear as these nerves switch back on again. And that's what we want to try to keep. Our goal is to try to keep you in that state as best as possible throughout the day. Why do I need carbidopa if levodopa was the magic medicine? Carbidopa is the chemical compound which lets levodopa go straight up into your brain and limits its use in other body parts. Remember, dopamine is used in multiple body parts, not just inside your brain, outside as well. And so I don't want to waste any of that gasoline. I want to let it all go up into the brain where I want it to work. So adding carbidopa along with levodopa lets most of that levodopa go into the brain. This way, I don't get a lot of the side effects which come from levodopa being used elsewhere. What would happen if levodopa is being used elsewhere? You get nauseous. You can get constipated. Your blood pressure can drop. You get lightheaded. There's a multitude of side effects which come about because dopamine is being utilized or being created artificially elsewhere in your body. This is why we made this combination.
Okay. I want to talk about on and off in just a minute, but what are the downsides of taking carbidopa levodopa? We get a lot of questions from people who are newly diagnosed. What are the downsides, if any, to taking it?
So all we're trying to do is recreate the dopamine levels which were previously there naturally in our brain. The problem with trying to give levodopa from the outside or dopamine from the outside is our nerves, when they shoot out dopamine and the other fellow receives it, it goes and recycles back into this nerve, and again, it's shot out. So it's very smooth release. The way it's released is very fine-tuned in a normal circuit. But when this nerve is damaged and we're trying to give dopamine from the outside, it's more in waves that it goes. So there's a surge of gasoline, this dopamine is formed, and then you switch on, and then it wears off. So initially, these nerves are relatively healthy to where they can pull back some of that dopamine that's shot out and recycle it. So I don't have to dose this levodopa that often. Over the years, they get more clunky, they get more deteriorated, and so the levodopa or the dopamine doesn't stay for very long. It doesn't recycle well. So basically, these nerves leak out the dopamine faster. So you notice that you're still getting the same kick like you used to, but it's getting shorter and shorter. It doesn't seem to last as long. And that happens because you're progressively deteriorating those nerves. Now, if you gave a person levodopa excessively, this person has Parkinson's, and you gave this person levodopa way more than what this person's requirement was, very aggressively early in the disease, you can instigate these sort of fluctuations earlier and earlier into this person's disease. Naturally, this person will fluctuate, will start to yo-yo every 4 hours, every 3 hours. If you let this disease progress and he's taking levodopa, naturally he is going to progress because those nerves are going to get more clunky. But that takes 5, 6, 7 years. Slowly it builds up as you take levodopa. So as you progress through the disease, the more deteriorated your nerves get, you're naturally going to show this. You can pull that earlier into the picture by aggressively dosing a whole lot of levodopa very early. And there are many cutoffs or numbers which are quoted by literature. Currently, the magic number seems to be around 400 milligrams a day, after which there is a higher risk of bringing on these fluctuations and dyskinesia earlier and earlier. So that is one theoretical possibility that can happen. But the way I look at levodopa is, as long as it's judiciously used, it is fuel for your brain. It is what keeps you moving. And so if I can achieve that movement, that smooth movement in you throughout the day with whatever dosing that I need, very gradually inching up, whichever level I get to, which achieves that, I get to keep you on that for a long stretch. So I don't feel afraid in using levodopa early at all. It was a very old concept where we want to save ourselves from levodopa. We don't want to use levodopa early because then you start to fluctuate. You start to have the dyskinesia like Michael J. Fox, if you've ever seen him on TV. But that's no longer true. We now know that the most common reason why you start to fluctuate or develop those excessive movements is disease progression. Your nerves are the reason why that same medicine, the same 2 tablets you were taking 3 years ago, now does something completely different. That's you, your brain, not the pill. That's your nerves getting more clunky. That engine is getting more and more damaged. That's all. So it responds to the gasoline very differently.
Okay, great. So let's dive in a little bit more on the on and off, and what's happening, you know, in people's brains, obviously, but it seems to be a real, like, it's so different for people, right? Like, there'll be some people that are, oh gosh, I've got to take it every, you know, couple of hours, and people ask, do I double, like, if I'm breaking it up, why don't I just take more throughout the day so that I don't have to deal with off times? But then that's not helping them either. And so what is going on when somebody is off and on? And you can talk a little bit about all the different types of off, like delayed on and that kind of thing. And what are some things that people can do about it? And maybe talk a little bit about also drinking and eating and how it relates to taking this med.
So as you progress through your disease, let's say about 5-6 years into your disease, your nerves are starting to get clunky enough to where, as I said, it doesn't recycle your prior dose for longer stretches. So when you first start off taking something like levodopa, you take it, the nerves switch on, and then it keeps recycling and shooting it out, recycling and shooting it out, meaning it's buffering itself with the old batch of medicine. So even though you're giving your second dose in the afternoon, you're not really feeling a dip. You're pretty smooth because your previous dose is still kind of cycling. You're just topping off the gas tank and it keeps you smooth. But as the years go by, that recycling in your brain is getting more and more poor because those nerves are dying. They're not as effective in recycling, so they leak out faster. That's when you start to catch the initial dips, meaning the way you would notice that is you switch on with your medicine, whatever dose that works for you, and then let's say about 5.5 hours, you start to gradually wear off in your symptoms. So meaning it's not all of a sudden you're switching off. Your symptoms gradually return. That little bit of tremor starts to come back in that left hand, or you start to feel a little slower in the way you plant your feet. It's a very gradual dip down. You're sliding down to zero. And you can usually catch it before you go to zero because your next dose is roughly about 20 to 30 minutes later. This is how you many times catch your initial off. This on and off fluctuation is a gentle wearing off. This is the most common way in which people manifest. And that's because the recycling is getting more and more poor. As the years go by, one more variable comes into this. So we've understood the problem which is happening within our brain, which creates this sort of fluctuation. As the years go by, that interval gets shorter and shorter. So we get that part. But one more issue is the fact that other circuits in your brain are also getting damaged, including your autonomic nervous system. These are special kind of nerves which control the automatic stuff in your body. The stuff you take for granted, not the pain, touch, temperature kind of guys. The stuff you don't think about, like your bowel movements, your bladder, your blood pressure, your sweating, your secretions, your drooling. I'm not thinking about pushing food down my throat all the way till I poop it out next day. It's happening automatically in the background. This stuff starts to get damaged. And as I said earlier, many times way before your Parkinson's symptoms starts, you start to get a bit of damage in your gut. That's why the slowness happens and you start to get constipated. So about 5, 6, 7, 8, 9, 10 years into the disease, as you go further and further into the disease, that constipation, that lack of motility in your gut goes all the way upstream to your stomach. Why is that so crucial? That your stomach doesn't move. Sure, it doesn't move. It's like sludge. Whatever you eat is slowly building its way down using gravity. So that levodopa medicine is absorbed only in the first part of your intestine. This is extremely crucial to understand. Most people think the minute I put this medicine under my mouth, it is getting absorbed and the clock starts again. No, It has to go down your food pipe, past your stomach, into the first part of your small intestine before it gets absorbed. So that's why you start to feel a lag in the medicine kicking in. It's like this medicine takes 30, 40 minutes to kick in. I mean, I took it. And this is why, very specifically, what starts to happen is when your gut slows down, these pills get stuck in transit. They get stuck in the folds of your stomach. And it takes you a half hour, 1 hour to push through. Or many times what happens, it does go through to your intestines, but food comes along behind it and pushes it through too fast, so you don't get a full absorption of the medicine. So what all scenarios can play out that way? One we talked about, a delayed on or no on, like the medicine fail, a dose failure. These are scenarios where the pills take a long time, a delayed manner in which it starts to kick in, or it doesn't even kick in, like 60 minutes later, it's still not kicked in because it's somewhere stuck in your food pipe or in the folds of your stomach. So this is one scenario. Another scenario is what we talked about, the too quick of a transit, where it's not getting a full absorption. What happens there? Half the medicine, I'm just making this up, half the medicine kicks in, a partial on. So usually when I take 2 tablets, I surge on. I know my arm smoothens out, my tremor gets better completely, and I walk faster. This time around, when I took my dose, my tremor got better. I'm kind of half loose, but I'm still kind of shuffling. Partial on. It's the same 2 tablets I've been taking for the last 10 years. What happened? Why this 3rd dose of the day decided to do this? So your gut is no longer your friend, and it becomes the second bottleneck other than the deteriorating nerves in your body. So these 2 variables create a more of a aggressive off and on. Unpredictability starts to seep in to your fluctuations. Previously, it was very predictable. I got used to this. For around 6 years into this, I start to feel like, yeah, I start to dip around 5 hours. I start to dip around 4 hours. So I plan my day. I know how to take my pills. I'm good. But now, randomly, my 3rd dose fails. My 1st dose of the day takes 1 hour to kick in. I can't predict when and how these pills are going to kick in effectively. So that's your stomach. This is why we have certain simple tricks that we use. Doesn't always work, but it's always good. Number 1, make sure you have a bowel movement every day. Why? Because it's like railway carriages. These pills have to get to that spot every couple of hours. Every 4 hours, it has to get there for absorption. If you're backed up with poop for 3-4 days of not pooping, you're going to have good days in a week and bad days in a week in terms of medicine response, simply based on whether you pooped or not. If you have not noticed this, look at this for the next 2 weeks and you will see how this matches your cycle. And so you have to clear the bottom end. But what about the top end? Remember, as I said, it takes time to get to the first part of your intestine. How can you accelerate that process? Make sure you take the medicine on an empty stomach so that there's no blockage, with a tall glass of water to flush it through. Kind of like a toilet. You're going to flush it through way past the stomach to the first part of your intestines. It can get there fast. It dissolves the medicine quickly and gives it enough time to absorb before food comes along. Why do I keep harping about food? Because the protein in your meal messes up the absorption of the medicine. This is why we like to say, right, spare at least 1 hour before a meal or 2 hours after a meal when you decide to take your medicine. That's the ideal recommendation. If you can spare at least 30 minutes to an hour, that would be great. But make sure, tall glass of water, you're chugging it down so that it gets there quick enough and it stays there long enough for full absorption before food comes along with it. And you're pooping every day so that everything transits like railway carriages smoothly. These 2 things, it sounds extremely silly, but you do this for 2 weeks, you will see a dramatic difference in the way your Parkinson's feel, even without adjusting your meds.
Yeah, I think that's great. I remember that from the time that we talked earlier, and we've had several people, we were kind of sharing that piece of the interview about drinking water, and people have said it's game changing for them. And I think the really interesting thing about the water is, to visualize it. you can visualize drinking that water and having it go through and the pill moving. Like otherwise, how is it going to move? You need to get it to move, right? The other thing that you talked about is constipation. Well, water can help with that. That's one of the things that water can actually help with. But what are some other things people can do? Because constipation is such a big, big problem.
So you want to divide it out into a couple of ways in which you want to tackle constipation. You know your gut is slow, right? We just talked about it. It's like sludge in there. You're using literally gravity to get it to go down. So you want to add liquids, meaning water, so that the consistency is looser. You want to add things in your diet which actually holds water in your gut, lets it stay in the gut. This is what we call fiber, roughage, right? So your green leafy vegetables, your dried fruits like your prunes, figs, raisin water, any of these things, the cocktails you can come up with where water stays in your gut so that it lubes the gut. Basically, you're lubing the gut. So this is the two ways in which you can use what you intake to make a difference. Number two, as I said, it's gravity. What can help a whole bag of intestines in your stomach? Contractions from the outside, meaning you exercising, you getting up and doing some chores, some small workouts. It's very dramatic. You will see this. If you exercised every day, enough of your truncal muscles, your stomach muscles, do a little bit of crunches, small things like this, it makes a big difference along with your diet in helping you poop every day. This is very dramatic. Then comes to the medicine options. Within the medicine options, we think of laxatives, we think of prescription laxatives and prescription medicines which add more fluid into the gut. Within the laxatives, again, conceptually, when we take a laxative, when we occasionally get constipated, whatever, we think of probiotics, we think of mild stuff, we think of doing it as needed. You see, the problem with doing something as needed, especially when your gut is completely clamped down, or if you plugged up already for 2-3 days, is that the bottom half is still pretty plugged up. The top half, where you've started to introduce a laxative today, is loosening up. So you're bloating on the top end, you're tight on the bottom end. It eventually goes through. What happens? You cycle between 2-3 days of constipation, then you decide to take a laxative like Miralax or Milk of Magnesia, and then you have a bout of diarrhea for 2 days because all of that backup stuff, and then you cycle back and forth. And so you never get a rhythm. So the way I like to say this is once you get a bowel movement going, once you've evacuated yourself, you start yourself on a daily dosage of something. It doesn't matter what, whatever works for you. Milk of Magnesia, Miralax, it's usually stuff like this which lets fluid build into your intestines. Those are the kind of stuff which daily, if you don't have to follow the full instruction and do a full cap. You could do a half cap, a quarter cap, what works for you, but consistently. It is not an as-needed option there. That's what gives you rhythm in your gut. Obviously, we talked about diet, exercises, all of that. Other than this, there's also a couple of other prescription medications like Amityville, Linzess, which we can use for gut options as well. Some people try to get onto a more spicy diet. It works for some, like eating more spicy, like peppers and chili, to kind of irritate. So many times, if you irritate the stomach lining, you have a bowel movement. You know this when you eat a spicy taco. You've been through this. And so the same approach in using a little bit of chili or pepper in their diet, that gets them going. A double shot of caffeine, coffee. They all have their baggages. Remember, if you do a whole lot of coffee, your tremors can get more active. So there's pluses and minuses to this. So whatever works for you, but that has to be part of your daily regimen. It is not an as-needed thing which you just think about once every 2 weeks.
Great. All right, thank you. I'm gonna look over for some questions now. So we've had a bunch coming in, and I just wanna let people know that if it's super specific, we can't answer it. And Dr. K can answer, general questions, but he doesn't know all of your details. So he's not gonna be able to tell you how much, medicine to take or how many milligrams or how many things like that. So definitely talk to your doctor if you have a specific question like that. Is Sinemet neuroprotective or just a treatment of symptoms? You can't hear? Can anyone hear me? You can hear me? Okay. I can't hear you. All of a sudden. Uh-oh. That is so weird. I mean, they can hear me. Let's see. Can you repeat? Shoot. Okay. Let's see. Maybe, I wonder if we should try psyllium husks. Yeah. Okay. Yeah, we're working on it. We're gonna figure it out. The other option, Dr. K, would be to just get off and then come back on and see if that works. Hold tight, everybody. Technical difficulties, no problem. Dr. K, you could, if you want to try and get off of the, just like sign out and then sign back in, that might work. Give it a try. Oh, wait.
Perfect.
Oh, wait, now I hear you.
There you go. Excellent.
Okay. So is Sinemet neuroprotective or just, helping with symptoms?
As far as we know, it is just purely helping the nerves operate at its normal pattern. This is all we're trying to do with Sinemet. So far, we have no data indicating that it is neuroprotective. There was some old science where we thought perhaps it was actually toxic for the brain or for the nervous system, but that has since been kind of washed away.
Okay. Is people that are allergic to Sinemet, is that a common thing? And like, what are some things that people can do?
So first off, most allergies to a drug comes from many times from the inactive components within the drug, or many times the actual dye of the tablet. Okay, so in my experience, I can tell you it's mostly to the yellow dye in the most standard form of carbidopa, levodopa available, which is the immediate release, which we kind of called it by its old brand name, Sinemet. So many times the strategy which I take is switching to another formulation of carbidopa, levodopa, which doesn't have the yellow dye. So you can use the CR formulations, you can use Rytari, you can even use that 10/100 carbidopa, levodopa, where you have less carbidopa in it. I prefer not to go that 10/100 route because it's less carbidopa. And we just talked about why carbidopa is so crucial for helping us prevent some of the dopamine-related side effects. So taking less makes not much sense to me, unless it's for these sort of reasons that I'm kind of manipulating. So there are other ways I would try to introduce carbo-levo and see if they still have this allergic reaction. Most of the allergic reactions which I've seen tends to be dermatitis, itching, or some sort of a skin eruption is the way I've seen it. Very rarely have I seen the asthmatic reaction where you feel like the tongue is swelling up and things like that. Now, a second scenario comes whereby you're allergic to carbidopa. This happens. And so we can find alternatives, unfortunately not here in America, but we can get the medicine procured from, let's say, Canada, elsewhere, where you can have other formulations of levodopa which doesn't have carbidopa in it. There will be another chemical very similar to its mechanism of action, but which is not carbidopa. And so that's many times the second step of what we try, is using other formulations which doesn't have carbidopa in it to try and treat the person. So the few patients that I have who consistently have this recurrent allergic reactions, we do this. The third thing is we get the dermatologist on board, which, by the way, every Parkinson's patient needs one dermatological exam once a year for their melanoma screening. Remember, melanoma kills you in 1 year if it goes undetected. So you always need a melanoma screening once a year with the dermatologist. But the dermatologist many times can work through the allergic reaction with medications which they give themselves. So sometimes we take a drug holiday where the person doesn't take the Carbidopa for a while. They get them on the right kind of medicines which suppress your immune system, and then we bring back in the Carbidopa.
Great. So the really valuable piece of advice for that is don't give up. And if it's not working, work with your doctor. And if your doctor isn't willing to work with you to find out this, find another doctor, because there are solutions. So don't give up.
Correct. And this is specifically what I mentioned before, the nuances which your movement specialists would be savvy of, because they've seen this. This is not a common problem. And all of a sudden, if you say, I'm allergic to levodopa, sometimes a physician might think levodopa is natural in your body. I mean, your nerves make this stuff. How can you be allergic to something you make yourself? So many times they don't think it through. So because we see enough of this, we know how to kind of mess around with it.
Yeah. Can you talk a little bit about dopamine dysregulation syndrome? What's happening there?
Dopamine dysregulation syndrome is where, what happens when I introduce this dopamine? We talked about get dopamine into the brain and the circuit will switch on. But unfortunately, I can't tell levodopa to take a left and then go take a right, go straight to the Parkinson circuit alone. It goes everywhere. It goes into your mood circuits, it goes into your thinking circuits, your sleep circuits. There's so many circuits which use dopamine. So many times we can artificially manipulate your mood circuits as well. And remember, dopamine is used in your addiction pathway. You can get compulsions, you can get addictive behavior kind of rev up with dopamine and dopamine-related products. And so dopamine dysregulation is a phenomenon whereby you start to have a craving for dopamine, where you need more and more dosings of dopamine to kind of feel like you're switching on, even more so than what you need. And every time you dip down on your dopamine levels, and this is a vicious cycle. You keep needing higher doses. The more you take, the more you have these big drops where you feel like your body's going through and off. And when we look at the person's too mobile, doing well, no tremors. If anything, he's just flailing dyskinesia because he's taking so much of levodopa. But they feel like they're off. They're coming off a high of almost. And the high can feel like a mental high. I feel cloudy. I don't feel elated. I feel kind of down in the dumps. I feel anxious. Sometimes it's a physical dip. Like they feel, oh, I'm cramping up. I feel pain coming on. And this keeps perpetuating the more and more and more levodopa that we give. It escalates out. There are certain subtypes or people who we typically end up seeing this. In younger patients, this can happen more frequently. Older, more skinnier women tend to get more dyskinesia, and they also end up kind of going through this sort of dopamine dysregulation. It's tricky, but it can be managed if caught early. And actually, the treatment is kind of like, when you get high on illegal drugs, what do? We actually slowly back them off. We get them on more smoother, longer formulations. It's an initial toughing out for a month or two, but they will thank you after 2 months, once you can get them down. Sometimes you have to go more aggressive, and we offer non-dopamine options like DPS, etc., just to give them the motor control they need, so that I have more flexibility in down.
Sorry, somebody's on this. I'm gonna try and turn that to mute. Okay. So some people said something, and also I just want to remind everybody that Dr. Aaron Haug is going to be here, and he is going to be talking about medications and lots of different types of medications. So we'll hold some of those questions. Let's see. is people are talking about swelling. Some people have mentioned, is that a side effect of drugs? Is swelling part of Parkinson's, or what's going on there?
So I'm assuming swelling usually in your feet or in your legs. Several reasons as to why you swell up in your legs and feet. The most common reason why we swell up in our legs is because your plumbing, your circulation is not very effective. Okay, so meaning the organ which helps pump blood into all your different body parts and sucks it back up is not working well, meaning heart failure or impending heart failure is the most common reason why you get leg swelling. And the same way, the stuff which filters your circulation, the filtering part, your kidneys, if they don't do a great job pushing out sodium and water, you're going to pack a whole lot of fluid in your bloodstream, which eventually seeps out. So heart and kidneys are the two major things we always look at, because in that age group, we're talking like in your 60s, in your 70s, you are losing warranty on many other organs too. And so those are the first things. You can't blame everything on Parkinson's always. First thing, be connected to your primary care doctor. You see one more person in that tag team as, hey, can you just run some battery of tests, get an echo? Can you just do blood work just to see if our kidneys are working okay? These are two things. Then we go down the track of actually mechanically in those limbs. Is there any restriction in the outflow of blood which helps create a pooling of blood? You know, you have clots in your veins, DVT or deep vein thrombosis, and they do an ultrasound of your leg. These are the kind of things we look for. Or if you're diabetic, or if another reason why you start to get infections in your foot, is it a local inflammation or cellulitis is what we call it. So these are things we look for from outside of Parkinson's standpoint. Then you come into Parkinson's as to why am I developing leg swelling, especially very advanced patients who are bedbound or wheelchair bound, where they're stuck in certain angles of orientation. When you sit in long stretches for long periods, you start to get more fluid accumulation in the most dependent, meaning the most rested part of your body. Which is why on a very long car trip, if you're not the one pressing the gas pedal, everybody else starts to feel like their shoe is getting tighter and tighter. Oh man, my shoe is getting more uncomfortable because your leg is slowly swelling up. The same phenomenon happens in very advanced Parkinson's patients. Then you get medication-induced swelling. There are a couple of meds, I'm sure Dr. Hogg is going to talk about this. Amantadine is a common culprit. And number two, Nuclacid, your psychiatric medicine for psychosis. These two guys can cause leg swelling. So these are common things when we pick up on this. Your dopamine agonists like Nearpex, Weeklip, Nupro, all those guys can give you the same thing. So we always will check. Sometimes primary care is like pulling their hair out going, why is this person's leg swelling? And we go, oh wait, you guys are on amantadine, and get him off his amantadine, and boom, gone. So this is why tag teaming is so crucial, because it interconnects many, many specialties together.
Okay. So again, with that, the tag teaming, and I think this is it's just a question that comes up a lot. If somebody does not have the access to a movement disorder specialist, they have a primary care physician, what are some things that those people can do to get the most out of their time with their primary care physician if that's the only doctor they're able to see?
Exactly. So if you're limited, and we talked about possibilities like, let's say, telemedicine approaches to connecting with a specialist sitting in New York or sitting in Oklahoma or wherever. I mean, I have patients connecting from South Dakota and all different states across the country. And so now we have that access. Let's say you don't have that access, okay? Your insurance doesn't pay for that. You're in a rural setting, you don't even have access to a neurologist. What can you do best? Kind of what you're doing right now, educating yourself. Why does that help? Because the more you know, the more savvy you are about your disease, you start to understand the nuances yourself. Like this medicine is useful for this, or this is what I'm going through off on. And sometimes going educated to a practitioner, when you have 15, 20 minutes with them and you're saying, look, I'm wearing off. I've read about this. This is motor fluctuations, and typically this is what happens. Can you work with me on this? So going informed, number one. Going with a plan, like, doc, can you help me tackle my tremor? Can you help me tackle my constipation? I'm trying to regulate my day. What do I do? Do you want me to try Miralax? No, you got another pill for that. So things like this. The more educated, keeping a diary and a quick summary list of what you want to talk to with your physician. Usually they open up, they hear and they go, okay, let's try to tackle this. Or let me call a friend who I work with, and just ask him over the phone. Curbside is what we call it among our physicians. And I'm just going, I get curbside from New York, from God knows where, all the time. But hey, we don't have a guy here. He's on sabbatical. Can you help me with this? Very easily they can work with this. But you need to be the motivated patient, which you are, because that's why you're here today.
Yeah, absolutely. That's great. That's great advice. And also, you can always, we've had a lot of people who take their Every Victory Counts manual to their primary care doctor and say, here, a little light reading. Well, they might appreciate it sometimes. So we have
best reading material I've seen, actually, to be honest, not because we're doing this seminar today. I've read through most of them. It's the most easily accessible from a patient perspective. So it would be a great reading material for you guys at home.
Thank you. Thank you. So, all right, well, we're gonna wrap this up. I know there are a lot of questions. A lot of them are medication related. So Dr. Howe will have a chance to answer some of those. And then we have some exercise questions. Dr. Mike will be able to answer some of those. We wish we could have Dr. K with us for another 3 hours. I know that we have enough questions to satisfy that, but we have to let you go. So thank you so much for being here. And we'll be in touch soon and definitely really appreciate your time today.
Thank you so much. Please be safe out there, guys. Go get the vaccine and have a blessed new year.
Thank you. Thank you, Dr. K.